Very good morning to all of you. So the next session is on the recent advances and updates of artificial intelligence in ophthalmology. I'm Dr. Rajiv Raman, and we start this session. We have a wide variety of topics which would be covered here, starting from language models to going right up to how we can empower the patients for AI with the AI agents. I have with me moderator Dr. Devang Angmo. We can start the first one.
So I would like to call upon Dr. Sheng Bin, who would be speaking on vision language model in ophthalmology. Dr. Sheng is there? Dr. Sheng's present is uploaded? No, it's not uploaded. Okay. So then I think I'll call upon Dr. Rajiv Raman, who would be speaking on recent advances in explainable AI.
So, good morning. So next few minutes I'll be sharing views on explainable AI and why explainability actually matters, because we know now many of these AI systems, they are showing high accuracies, but there is lack of transparency. And one of the thing in healthcare is decisions must be understandable, and there's also a regulatory push. It has been mandated by FDA and EU regulations that the AI algorithm should show how it could find out the problem, and definitely it helps in building trust among the clinicians. There is something called as a black box problem. That's what has been described. The typical deep learning models, they make very complex decisions, and there is no clear visibility why they predict a certain diagnosis. And definitely there is a skepticism of a clinician because of the hidden biases and the errors which can happen. So basically explainability aims to answer what the model is seeing to predict or to give a diagnosis of a disease. So we have people from Google, and this was the Google Health AI which was developed. The initial development, it showed good high accuracies, but the initial model had no explainability, and to address this, the post hoc explainability tools were integrated, and now it can tell that what it's looking at, and that would help them getting the regulatory approvals too. So it is now mandate for any of the new algorithms which are coming to show the explainability to get various approvals. There are various techniques which are used. So there are something called as attribution based methods. So it highlights the pixels which are used for maximum decision making, and many of these are listed here. There are certain methods where a part of the image is occluded, and then we try looking at how the AI algorithm performs, and then determine which are the parts it is looking at to give a diagnosis. And now more recently we have many intrinsic interpretability models which can have a self-explainability which is inbuilt into the algorithm itself. So we did this study where we tried evaluating various explainable deep learning models for ophthalmic diagnosis, and to my surprise, because this is done by one of my collaborator who is a AI scientist, and he said that there are about 13 or 14 of these methods which can be used. So we used an algorithm which was trained on a large data set to detect CNVM, diabetic macular edema, and drusen. And then we used all these methods, and it was rated by 14 clinicians too, that what actually clinicians saw to give a diagnosis and what the explainable AI algorithms actually was suggesting. And then we had a matrix of 0 to 5 to see what is the clinical relevance. Really, is it clinically relevant? And what we found, one of the method called as a deep tailor, it focuses on the fluid areas pretty well. There were other methods which highlighted the boundaries of lesion pretty good, and there was some which was very selective, but it was very precise. So what we found, that deep tailor method seems to be highest rated, means that what the algorithm felt is important and what clinician felt is important was same. The other algorithms also performed well, But the most popular of them, which people use more common, is something which underperformed a lot. And probably from a clinician point of view, the explanations that highlight the pathology comprehensively, which avoids noise and guides them to a suspect area, is something which they liked most. There was moderate inter-rater agreement, because that's again very common as far as clinicians are concerned. What everybody looks into is pretty different way. More experienced clinician gave more consistent rating among the things. And so this was what our study said, and we found that there are some methods of explainable AI which are pretty good for ophthalmic diagnosis. Probably tracking mechanism, that's one of the work one of my collaborator from Columbia, Dr. Kaveri, is working on. She's trying to look at using the eye tracking, what the clinician actually looks into, highlighting those lesions and then trying to develop an explainable AI based on that. Another possible use can be like this is a more recent of our one of the work which we tried looking at detecting anemia in people with diabetes from our population based cohort, and we could make an algorithm which was pretty accurate in detecting even the mean hemoglobin level. So we were very keen that what actually because as a retinal surgeon, I cannot, except for when there are features of anemia on the retina, we cannot predict the hemoglobin levels. So AI actually looked into these peripapillary areas, and we did a little more detailed analysis of what actually in the peripapillary vasculature happens in anemia, and we could find that it's the vessel density, the tortuosity, the vessel thickness in the peripapillary area which probably contributes in understanding whether anemia is there or not. So one way explainability can be used is probably finding there are subtle clues which we don't routinely look in our clinical practice. So the current trends are shifting towards hybrid models. The explainability is integrated into the model design. There are new matrices which are emerging now, like faithfulness and completeness, and challenge is the multimodal explainability, where we integrate fundus photo, clinical data and OCT, and AI generated textual explanations has also become a reality with the large language models. So to conclude, explainability is essential for a safe, trusted AI deployment in ophthalmology. The recent advances shows promise but needs continuous validation, and in future probably the clinician in the loop AI with transparent decision making pathways is something which will have more bearing and more acceptability as far as ophthalmologist is concerned. So it's not just a feature, it's a bridge to a clinical acceptance, and I think many of the challenge of today's AI algorithm, many of them are not clinically used by the clinician, and this is something which will definitely help as far as adaptability is concerned. I'd like to thank my research team for all the work we have been doing. Thank you very much.
Thank you, Dr. Rajiv, for such an excellent presentation. Now, next I would like to call upon Dr. Kai Huang, who would be speaking on advancement in robotic assisted ophthalmic surgery. The presentation is uploaded. Dr. Kai Huang's, is it there? चल रहा है? Do we have a problem?
I don't see.
If it's not there, we can take the next presentation.
I think we'll have enough time to discuss.
Okay.
Because I think one or two speakers have not come. So any questions till now, and then we can call Dr. Devlin.
Yeah, Dr. Devlin is there. Yeah, he can be Yeah, you set up in the meanwhile, we'll take up questions. So Dr. Devleen would be speaking on an All India Institute of Medical Sciences collaboration on AI.
Rajesh sir, nice presentation. So I only wanted to know, is there any correlation you have arrived at with the level of hemoglobin and the evaluation which you have done? Meaning to say, with the vessel density, tortuosity you have been mentioning, is it any matching?
Yeah, so we did a binary anemia present or absent,
Yes.
because in this dividing it into groups, the numbers will become much small to have a real meaningful comparison. But what that table was showing was anemia present and absent. So
Not the
definitely
grade of anemia, right?
not the grade of anemia there.
Thank you, doctor. So my question in terms of explainable AI, so I understand doctors, clinicians want to really understand, but this model of that when an AI says something, taking it as some truth, and then figuring out will it play out in the future, or explainability has to be very important. The second question is what do you see after 10 years? Where would all this be?
See, there are two aspects. One is the diseases which we can also diagnose, like diabetic macular edema or choroidal neovascular membrane, and what as a clinician we look into and what the AI is looking into. We want that probably it should match. We look into, if it is matching means I would say that okay, that's pretty accurate. No, there are certain things like anemia. We really don't know unless there are some lesions in the retina because of anemia. We cannot tell based on the retinal image that this is anemia, and there probably it's good to explore what AI looked into and then see that probably are there anything like vascular changes there which we don't routinely see. So both ways. Dr. Robert, any thoughts you have on explainability? Yeah.
Is it switched on? Yeah.
Agree on the outcome. That's actually most important if you're trying to make an associative finding through an AI algorithm. So, a lot of diseases, we don't have good definitions, we don't agree. So you really have to come to a consensus of either a science-based output or a clinical-based output. So whether it's a clinical finding that we all make decisions on, or it's a scientific finding where there's some pathophysiology explanation, those are the two ways to then make the associative explainable finding of what you see from a large data set of, let's say, images or other results.
Yeah, with regards to the data set and the data which is being collected from patients,
Hi.
with regards to the data being collected from patients, we are using images from your machines and previous past collection of data. So how do we actually retrospectively get consent from patients who have actually not really knowingly or unknowingly contributed to the AI research? So where's the legal standing as far as using this data, even though it belongs to us and they may have signed a consent initially saying I'm willing to undergo examination, but have they consented for the AI being used on their data, even if the data has been made anonymous?
So there are two things. There are certain, like for this study we had used a epidemiology study data set where we took a consent that this data would be used for future research. So, and even our clinical consent form actually has that though we put as a clinical, but we do put there that any of the images, any of the thing which will be taken during this would be used for any future research or academic purpose. So I think a good way to have it is inbuilt into your consent which you are taking initially, because that helps. That's what happens at my institute.
Okay, Dr. Devleen, I think we'll take up your presentation.
Thank you. Hi everyone, good morning. I work with Google. My name is Devleen. I'm not an ophthalmologist, I'm a diabetologist by training. Just wanted to give that disclaimer before I started. Today we're going to be talking about a real world AI deployment use case that Google has been able to do at AIMS. AIMS for our international colleagues is All India Institute of Medical Sciences. It's one of the flagship health research and health education institutes in the country. I'm an employee of Google and I own Alphabet stock. Google's Health AI mission is to build mobile
mic
and
is not
AI-based tools that
Audio
enable.
visual, can you please set up the mic? The second mic is not switched on, is it? Yeah, okay, thank you. We're great,
Better?
yeah.
Okay. Google's Health AI mission is to build mobile and AI-based tools that enable equitable access to sustainable, scalable, and data-driven healthcare. Our mission has been to think about health holistically alongside our partner ecosystem. Underpinning our work and partners' work is the interoperability and data processing infrastructure that we are able to provide to almost all our health partners. We are also creating AI diagnostics, mobile health sensors, and leveraging geospatial data. There are climate and health community insights that come out of our data and AI. Finally, a group of partner mobile applications are built which help us deliver impact. We have a variety of research focused on using AI to improve screening and diagnosis of disease. Some of this we're going to talk about today, which is focused on diabetic retinopathy, but we've done other screening, we have other screening tools which use AI as well, especially for tuberculosis, which today has been deployed across Apollo. We have something for mammography, which helps to detect cancer, and we are in the process of building out other tools as well, two of which I'll talk about next. One of our AI tools has been to use blind sweep ultrasound in order to be able to triage high-risk pregnancy. A tool like this today is of immense value in under-resourced settings, in places where there are little or very few trained physicians available. We've been able to deploy this across Africa, and hopefully we should be able to scale this across other LMIC countries as well. Another piece that we've been working on was to basically, which I think Dr. Rajiv also touched upon previously, is to use fundus images to help detect non-communicable diseases. We are in the process of trying to figure out how the same thing can be used with external eye images, and these would be external eye images that are taken with the help of a mobile phone. This is still research in progress, but initial findings look good. Our work is possible only through local technology implementers. We work very closely with local funding bodies, with governments in order to influence AI adoption and build out AI infrastructure. But all of this is only possible with our on-the-ground partners. I'm now going to talk a little bit about how we go from research to actual product deployments. So the first solution that Google has been able to deploy from research to product to actual real-world deployment is something that we call as ARDA. This is an AI solution which is specific for screening for diabetic retinopathy and diabetic macular edema. We've done a lot of research to make sure that the accuracy is similar to that of eye specialists. It helps to enable early detection of diabetic retinopathy, and it also provides instant screening results. Our approach has been to start with a model that we developed. We then went ahead and validated it using retrospective clinical studies. This was based on data sets that we sourced from across the world. We then, when we moved from research to productization, we did a prospective study, which also was done globally. And ultimately, we've been able to implement that research across India and Thailand. As you're all aware, there are certain regulatory and compliances that exist globally at this point, which limit the deployment. But some countries we are in conversation with in order to make sure that this reaches the kind of scale that we hope it will. So why India? India is one of the diabetes capitals of the world. The percentage of ophthalmologists available compared to patients is abysmally low. And there is a very large urban and rural divide. One of the goals that we had when we were developing screening solutions is to create maximum impact and meet the patient where the patient is present, irrespective of what kind of resources might be available to them. Which is why India is a geography that we do a lot of work in. We also work across some of the other LMIC countries, Thailand being another one. The next bit which is important for us to figure out is where do we deploy a solution like this? There are certain parameters that we use in order to understand feasibility. The first is, of course, the kind of impact we can create. So the number of patients that a particular facility is seeing, what is the percentage of trained physicians that are available there, and what would be the kind of access which is available to patients. The other bit which is very essential for us is to understand if this is technically feasible. So I'll explain this with an example. A place where there is no technology backup, right? So for example, no EMR, no HIS, it is very, very difficult to deploy an AI solution because the AI solution runs on a basic technology infrastructure. And this in India has been a very big challenge that we faced. So coming to the use case that we have at All India Institute of Medical Sciences, one of the pieces, I'm sure all of you are aware that we've deployed ARDA across ophthalmic institutions. So Arvind Eye Care has been one, Shankar Netralaya has been another one. But what we actually wanted to do was go to the root cause of the problem. So diabetic retinopathy is best treated by repeated and early screening. We wanted to actually go to a place where diabetic patients were coming in and day out for checkups, reviews, and things like that. We also wanted to work with a younger population. So 18 to 45 was the age group that we were looking at. We happened to come across Dr. Nikhil Tandon, who's the professor and head for Department of Endocrinology at AIIMS, and Dr. Pradeep Venkatesh, who's a retina specialist at AIIMS, and pitched this idea of deploying ARDA within the endocrinology department. This is probably a first of its kind where a diabetic retinopathy screening tool was actually deployed in the Department of Endocrinology. We did a site assessment, and as all of you know, AIIMS is not the most technologically savvy organization. So we worked with a system integrator called Forus Healthcare, that basically set up the entire infrastructure in order for the screening to take place. It also helped that Dr. Nikhil runs a clinic which is called Diabetes of Young. It is a clinic that he, I think, runs every Saturday, and he has a patient registry of over 10,000 patients in that. So the study that we did was validation of the deep learning model for diabetic retinopathy in patients with young onset diabetes. The age group that we considered was 18 to 45 years. Our hypothesis was that most DR models, or deep learning models as we call them, are developed and validated on cohorts of patients that are much older. So they would be either in their late 40s or early 50s. What we wanted to do was to understand if our model could work in a younger age group, largely because there is a trend of young onset diabetes now, which is picking up. And secondly, in younger individuals, there are certain anatomical differences within the fundus, especially something that we call as a prominent retinal sheen. So we wanted to understand if our model could perform in the presence of a retinal sheen. Can I take a minute more?
Yeah.
Thank you. So we basically had a younger cohort and an older cohort. You can see the data here. And some of the findings that we were able to get were that deep learning systems are very, very good in screening for diabetic retinopathy, irrespective of the age group. The problem that we faced with the retinal sheen was in the diabetic macular edema, where the sensitivity of the model dropped, especially in the older cohort amongst these young patients. And what we attributed that to was the retinal sheen was misunderstood by the model as diabetic macular edema, while it wasn't that. We believe that we should do further studies on this and get better imaging and other imaging in order for the same thing to be explored further. Some of our insights and learnings have been that model development is only half the battle. The other half is to ensure that it works on the ground. We definitely need a strong buy-in and support from local partners on the ground. There has to be staff technology support available. And I think it is very, very important for us to have principal investigators who are willing and committed to the cause, who can actually move the system, especially in a government setting. That's it. Thank you.
Any questions? Anybody has any questions? I think great work and really congratulations. The major challenge in India is that we don't have so many fundus cameras. We have 130 million people with diabetes, and if you cannot actually have so many cameras to take images. So if we think that every year we can have something which can be used as a screening, probably some other method, like one of the things which we have been trying is the risk factor based, so that we can triage. So there are a lot of, the good thing in India is there are a couple of good population based studies which have identified risk factors, and so what we have tried looking at is, can we use these risk factor to triage patient to get a photograph, because you cannot take a photograph for all. So that is something probably in our country that may be the way to go. My question about type 1 diabetes is that, though you said sheen, but also the lesions of retinopathy, because based on that you can say if there are no lesions, probably the sheen is, could you work on mitigating this problem of sheen identified as DME?
So we not in this study. It is what we've been able to identify is that the sheen is a problem for the model. Mitigation of that is something that we haven't as yet started to work on.
Because it is very logical that if there are no lesions of diabetic retinopathy on the retina and there is a sheen, it cannot be DME. So it needs just one step to be put and you can get away with that.
No, absolutely, fully agree with you. It's we would also like for the model to be able to identify this step. At this point, the model is not able to.
Right.
Yes, absolutely.
Data has to be fed.
Yes.
That model will start reading it as a normal.
Yeah.
Diagnosing it as a DME.
Absolutely. So that would be the step 2 for the same study.
But there are few studies now which have shown the models which are for type 2 diabetes reasonable, because the lesions of diabetic retinopathy don't change in young onset diabetes. It's not like there are some new lesions. So what was the basis you felt that, one is I understand sheen, but do you expect that the performance would be different between both?
For type 1 and type 2?
Type 1, type 2, or I would say young onset, because these are, I don't know whether type 1 they were particular or because the lesions are same.
So diabetic retinopathy detection was absolutely perfect. It was the diabetic macular edema detection, the sensitivity especially, which was impacted by the sheen. So DR is, I think the model is doing really well on that, more than 95% this thing. But DME was where we think that the model needs to be tuned better.
Can I ask a question?
Yes, please.
Yeah. So in terms of this using smartphone, right, the research phase which you're saying, do you see a real promise, as doctor said, that the fundus camera, right, usage in India, in the population, but is it possible to see really screening using normal smartphone cameras in coming years?
I guess
So I'll answer this in 2 parts. We were actually able to get external eye images across the globe and train the model on it. The performance is not what we would expect. It needs to get better, largely because of the quality of images. There's a second aspect, which is a handheld fundus camera. The handheld fundus camera images are, and there's a lot of them available. These fundus images, our model does not perform as well on the handheld fundus camera images, largely because of the quality. And we've tried to do this across different models, across almost all companies that today offer it. We have not been very satisfied with the model performance.
Right. And the second question would be this onset of foundational models like RedFound and all.
Yes.
Do you see a promise there?
We also have foundation models now available, and I think from if we want to scale AI solutions, foundation models would be the way to go, because each setting, or at least in India, each healthcare provider is looking for a custom solution which fits into their workflows, the way they operate, and custom solutions become very, very difficult to offer. Foundation models allow for people to use a foundation model, build up the front end and the back end the way they want to, and integrate it within their system. So
Google has a foundation model for ophthalmology specifically?
we're in the process of building it.
No, there are two foundation models which are already there. Dr. Pierce Skeen has got a foundation model from Moorfields. There's another one from China which is specific for ophthalmology. Just answering one point which you said, various cameras. So I had an opportunity to look at the Thailand data of Google, and the beauty was they had 600 cameras and there were about 12 type of cameras across the country. So we did analyze that is the camera type and the performance of AI different, and what we found that if the gradability, definitely there is a difference between the cameras, but once the image is gradable, the performance of AI seems to be same.
Yeah.
And just the last question. the
Next,
deployment.
meanwhile, I'll just call Dr. Kabilan Ilangovan, who can just put up their presentation, and we have the, yeah.
So I'll be quick. The last question in the AIMS, which you said the deployment, this required a regulatory approval?
Yes, yes. It requires a regulatory approval, it requires an ethics committee approval, it requires, I believe now even an ICMR approval.
Do you think these things are important when such a large case, or this is, there is a Hindi word hawa, right? Is it like when AI technology is so, I mean, what as a person who you have been there, is a regulatory thing just being used to kind of, bring bottlenecks and stop
We should
progress?
discuss this offline. I can't publicly say anything. Thank you, everyone.
All right, so good morning, everyone. All right, so I mean, fortunately or unfortunately, I'm not a clinician. So I'm actually an AI scientist from Singapore Health Services, and the AI lab is led by Professor Daniel Ting. So it's always an excitement to actually share about large language models and AI, especially with the Gen AI explosion, right? So without further ado, I'll just go into the presentation. So I have no conflict of interest. So just a quick check, right? How many of us are actually using large language models day to day, right? How many of you guys, right? I see a couple of hands. So I think the idea of large language models actually kind of had its inception in 1990 actually, in terms of the statistical language models. And over the 3 decades after the inception or the development of transformer architecture by the Google team, they then had the pre-trained language models, and then we move into the large language models. So if you look at the large language models, they are now seen as universal solution experts, right? Basically, you can ask it anything and you will come out with a response. Whether it's factual or not, that's another discussion for later, right? But you get a response. So here are some like popular LLM engines, right? That is already surfaced now. I mean, it's not an exhaustive list, but if you were to look at it and how you categorize LLMs now is that you actually have them as closed source LLMs and open source LLMs. So what's the difference here is that open source LLMs are those that you can potentially locally host if you have enough compute resources. But if you look at the closed source LLMs, they are actually hosted elsewhere, and you only can access them via API calls, and that leads to a lot of data issues and safety and ethical concerns that open source language models can easily mitigate. So here are just 2 papers that has been published in Nature journals, and it's actually a primer papers, and one of the review articles has actually been published by my team, and a co-author Ting Fang is also here. And this paper has actually garnered over 2,000 citations in less than 2 years, right? So it just shows how prevalent the use of large language models are going to be in healthcare in general and also in ophthalmology. So just in a nutshell, what are the applications of LLMs in healthcare, right? It is actually quite diverse and quite exhaustive, starting from administrative tasks like doing discharge summaries or generating operative notes, to even building a research assistant tool for doing literature review. And also, if you want to look at the highest hanging fruit, is actually looking at clinical management and coming out with treatment plans and protocols. So, but I believe now when you're using large language models, we are now very familiar with the limitations of it, right? And whenever you talk about large language models, you will definitely have to mention the term or the word hallucinations, right? If you don't say hallucination, means you don't actually work with large language models. It comes to that, essentially. And these hallucinations lead to clinical inaccuracies. And then also, the fact that these large language models have been pre-trained on past data, they actually lack recency in terms of the knowledge, right? And also the lack of interpretability. If you were to look at the architectural design of large language models, they are actually basically predicting the next probable token, or in the case, words, right? So you don't really have the explainability to these large language models. And of course, the ethical and safety concerns depends on which engines you're planning to use, whether it's the open source or mostly related to the closed source models. But these limitations can be mitigated by few techniques, right? One is prompt engineering. Next is actually retrieval augmented generation, which I'll talk about later. And also fine-tuning and pre-training. And pre-training in the sense that you can actually do continual pre-training with open source models. And actually, I just wanted to add that the first two options actually only applies to closed source models. You won't be able to do fine-tuning or pre-training with closed source models. You only can do that with the open source models. So what is RAG, right? So this is actually the formal definition of RAG, essentially. But to me, when I want to actually talk about RAG, I actually try to simplify this as like an open book exam, right? I mean, everybody is familiar with this. You actually have a system of, basically when you're doing an open book exam, you're actually having a student answer a question with referenceable notes and textbooks, for example. So basically a student will then do the information retrieval and then generate the answer. But when you look at a RAG with the LLM, we're actually going to split these two rows and these two rows as a retrieval agent for the information retrieval, and also to generate the answers then when you use the LLM. So how does that look like, right? So first you have a user query that goes into a retrieval agent. So I say retrieval agent because it's a very generic term to mention. It can be a Python code, it can be a Python script, or it can be an LLM essentially also. But what it does is that it's going to convert the user query into a retrieval query and extracts the relevant information from the external knowledge base. And then passes the user's query together with the external extracted information to the LLM, and effectively you get the answer from a user standpoint. But how the LLM is going to process this, right? So this is where you actually have a system prompt or an instruction where you can actually assign a role, whether it's a medical chatbot, and then you can inject where you want the retrieved text to be or the contextual information, and followed by the user's query. So there are many different types or different techniques of RAG essentially, right? So I'm just going to briefly mention all this. All of these methods are actually kind of humanized in some extent, right? If you look at it, it's corrective RAG, self-RAG, speculative RAG. They kind of humanize this to make sure that the LLM is actually validating and correcting itself and making it better. So this, and actually I have a link below that actually is talking about 25 types of RAG essentially. So I'm not going to bombard you guys with all this information, right? So I'm just going to talk about the agentic RAG, which is what the entire space is moving towards. I'm not sure how many of you are familiar with Manus from China, and also Anthropic's computer use. I don't know how many of you are using that. Basically, you can actually automate your task using such agentic LLM engines. So, but what is it doing in RAG in ophthalmology, right? So, unfortunately, this is just a quick PubMed search, and there's only 3 articles that's being published in ophthalmology, right? Retrieval augmented generation in ophthalmology is the search query, and we only got 3 papers so far. So what's the reason why we don't have so many publications in this space? So then moving to the cons of RAG. So basically, RAG is actually data dependent. So if you have poor quality data or outdated data or irrelevant information, you then get misleading outputs. Followed by that is high complexity. So if you look at it, there is a retrieval component, and then there's an interaction with the knowledge base. So this actually leads to a complexity of the pipelines using RAG. And of course, it's scalability. If you're looking at different data types like tables or even PDF documents that have embedded tables and text and images to it, it gets very complex in terms of how you want to scale the solution. And then lastly, the latency, right? Because you actually have a full-fledged what you call retrieval pipeline and complex LLM pipeline that actually limits its application into real-time applications. So just a quick sharing of what we have done in my team as a pilot study. So we actually wanted to develop and validate a lightweight LLM for clinical decision support using ophthalmology case scenarios. So basically it's a case scenario. So conventional approach is actually what it does is that we usually have a patient case as a query, and then the knowledge base is based on the guidelines and protocols, and the output is actually a surgical fitness assessment and medication dosing optimization. So why I chose these two outputs and why I've linked papers below is that these are the non-ophthalmology work that my team has done. And for the surgical fitness assessment, it just got published today in NPJ Digital Medicine. And the preprints are here. So, but for this use case or this pilot study, what we have done is a different approach, right? We look at a non-conventional approach where we are actually using patient case to reference with patient case, and then provide the top 3 differential diagnosis and treatment plan and triad disposition. So this is just a preliminary results that we tested with Llama 3, 8 billion, Mistral model, Titan, Text Express. So if you look at the native accuracy, is actually the LLM's native responses, and then the RAG accuracy is with the knowledge base or the past patient case information. So we actually tested this on 18 patient cases, and of course, Mistral as the better performing models. And this work is actually been published or submitted to as an abstract to ARVO. So if you guys are going to ARVO next month, hope to see you there and we can discuss further on this. But I just wanted to close off, right? I think because most of you are mostly clinicians and physicians and ophthalmologists here. So I just wanted to say that the go-to method to actually make LLMs to reason was actually using RAG, right? Because you basically have a knowledge base, you have clinical groundedness, and then you get a contextual understanding in terms of generating clinically relevant responses. But what is happening now is that we are actually looking at reasoning models, right? Now we have DeepSeek, we have O1 models from OpenAI. So my question to you guys, and that's what I'm going to end off this session with, is that are these reasoning models or logical reasoning models equivalent to clinical reasoning? So this is something that I'm not sure. I'm actually working on evaluating this, but happy to hear from you guys. What are your thoughts on this, right? So with that, thank you, and I want to extend my acknowledgement to Professor Nariyatin.
Any questions or any comments?
Wonderful session for Dr. Rajiv to ask whether the anemic changes or IDDM versus a NIDM diabetic. Now, our objective is to target the retinal blood vessels window, because the blood cells which are flowing there would give a lot of information for anemia, any other disease. For example, leukemia, you can freeze the white blood cells, and the red blood cell characteristics, platelet characteristics, and for the sludging of the blood vessels, blood circulation in the diabetic, what stage of diabetic, duration of the diabetes. Now, whatever is obvious for clinical thing will not give too much information, but if we can pick up those cases in the pre-diabetic or before the advancement of diabetes or anemia can happen, I think that will be a wonderful thing.
Thank you, sir.
Yeah, octa images or some nuances in the imaging system would give a better response for those things. Thank you.
Not really. One more question I want to ask.
The question whether what you talked about the models, will it be useful in clinics?
Right.
And my answer is full yes. Any modern clinic is not a one-person show anymore. You're a teamwork of people, some doing intake, then the second phase intake, and then you come to the specialist. And because you're dealing with humans, you have a lot of inconsistency.
Right.
And
right.
I think these models will harmonize, make it more equal and more
Right.
predictable. So yes, and it will get better. I'm a full believer. We're working in our clinic in in these models, etc. We're doing summaries of all our old patient files. We're practicing now with true large language models to do the questionnaires to the patient, but we have our assistants doing the actual questionnaires for quality control, and we believe in it. It's the future.
Yeah. I think I just threw the question as a curveball, actually, just trying to get affirmation from clinicians essentially, right? Because that's what I actually have to face. So it's good that we are seeing a lot of this acceptance of LLMs now, right? Thank you.
Okay, thank you. Good morning, everyone. I'm Ting Fang, a resident from the Singapore National Eye Centre. Thank you for this opportunity to be here at APAO to learn from all of you. So we have learned from Kabilan's sharing earlier on the development of large language models in healthcare. And we have seen how LLMs leverage on deep learning techniques, transformer architecture, and attention to learn complex and meaningful associations among vast amounts of unstructured text. So generative AI applications bring an advantage with their ease of use and interactive conversational dialogues, and now the ability to integrate image and text data to predict outcomes. So with its ability to generalize to unseen tasks, there's limitless possibilities of use cases now seen in healthcare and ophthalmology. And we have learned earlier as well the different strategies that have been used to improve on base LLM models to align them with domain-specific use cases. However, as Kabilan has also mentioned, the cautions against LLMs stem from hallucinations, fabricated content, and falsehood mimicry where incorrect information can be presented in a seemingly confident manner and can potentially mislead the users. And hence, effective evaluation is needed to help to validate LLM applications for use. So in its early phases, we have seen benchmarking data sets being used to grade LLMs on MCQ question banks on medical board examinations. So these are largely in multiple choice format, which allows summation of scores and comparison amongst other LLMs and also against clinicians. But with time, as newer use cases are being developed, we have moved beyond MCQ question banks, as these are not as reflective of the clinical competency in real-world practice. So we have also seen traditional quantitative metrics from natural language processing being used to grade LLMs, but these focus on text similarity, and they use exact word matching to give a score to the LLM responses. This may not be as relevant in healthcare use cases as compared to traditional tasks like translation or summarization. As to clinical questions, we often do not have a model answer, and the exact word matching that these scores focus on may fail to capture the clinical nuances in the clinical context. So we propose the use of SCORE, which is a multidimensional framework that aims to facilitate a qualitative assessment of LLM open-ended generated responses. So there are 5 key aspects outlining the evaluation graded on a scale of 1 to 5 to be graded by clinical domain experts. So first, safety looks at an LLM-generated response that does not contain any hallucinated or misleading information, and to prevent harm to the user. Next, consensus and context focuses on accurate and relevant information in the generated response that is non-generic and specifically addressing relevant aspects of the context in question. Objectivity looks at responses that prevent discrimination to any particular ethnicity, gender, or any condition. And reproducibility looks to see the consistency in the generated response to repeated questioning of the same question. So the focus here is not on word-for-word repeatability, but ensuring the contextual consistency in retaining pertinent information. And finally, explainability looks at the response justification, including the reasoning process, and also including supplemental information where relevant, such as any website links or reference citations. So we conducted a head-to-head comparison to compare quantitative metrics versus the SCORE framework in the evaluation of ChatGPT-4 Omni-generated responses to healthcare-related questions. So using the quantitative metrics, the responses were deemed as suboptimal and scored less than 0.1 to 0.5 out of 1. On the other hand, using the SCORE framework, the responses were actually deemed clinically accurate, scoring 4.2 to 5 out of 5. Looking at one example here, I know it's a busy slide, but this is a question on the genetic factors influencing azathioprine use. So using the quantitative metrics, it actually scored it very poorly, 0.05 to 0.65. But when we look closely at the response, it correctly identified the importance of genetic polymorphism in affecting toxicity of azathioprine and identified the need for genetic testing prior to initiation as it may affect the adjustment in therapy. So using the SCORE framework, this allowed a more nuanced understanding of the clinically relevant aspects of the response. Similarly, in another question on symptoms of diabetic retinopathy, the LLM-generated response correctly identified the importance of regular examinations for early detection, as symptoms in diabetic retinopathy may not be apparent in early stages. Using the quantitative metrics, again, this scored relatively poorly, and we can see that it's particularly in metrics like BLUE and ROGUE, which focuses on exact word matching, which may not be relevant in clinical answering. Using the SCORE framework, this identified the answer as accurate, but it scored poorly in the consensus and context component, as we could see that it listed certain symptoms like fluctuating vision and impaired color vision, which is not entirely unsafe or inaccurate, but is not as typically observed or as contextually relevant in diabetic retinopathy. So in another experiment, we used SCORE to efficiently compare between different medical-based LLMs. So these medical-based LLMs were developed by other teams from base LLM models using fine-tuning or pre-training using medical data sets. And we wanted to see if these LLM models can perform well in answering ophthalmology-related questions. As you can imagine, human grading is very tedious and time-consuming. So using the SCORE framework, it allowed us to efficiently grade these questions quickly, and on closer inspection allowed us to look at the responses that were being graded. So we found that MET-LAMA 3 performed the poorest, and on closer inspection of the gradings, we saw that this scored poorly, in particular in the consensus and context component, and we saw that over a third of the responses actually contain hallucinated and inaccurate information. And the SCORE gradings were highly aligned between the different graders. So SCORE shows an example of a qualitative and multidimensional evaluation that can potentially be standardized across different use cases, generating LLM open-ended responses. While further validation is still needed in other domain-specific use cases, this is potentially a unifying evaluation that we can use to allow better comparison against different models. Because now we see there are models after models being evaluated and new use cases being pushed out, but evaluation is often inconsistent and varied amongst different models, so we can't have a good interpretation or assessment of the models at a glance. Using a unifying evaluation framework may potentially allow us to better uncover insights into the evaluation that is important in further enhancing and improving the performance of these models. And one other aspect that we can potentially apply this is also how we have seen LLM-based evaluation being explored, where LLM models are used to evaluate LLM-generated responses. And using the SCORE framework, we can potentially incorporate that into the input prompt to guide the LLM model to know what to critique and how to assess the models. And this can serve in a potential hybrid model where it can serve as a first pass before the clinician has a closer inspection on the gradings to have better insights and more efficient evaluation. Thank you.
Thank you for the presentation. Any questions from the audience? So I'll call upon the next speaker, Dr. Robert Chang from the United States, who would be speaking on empowering patients using AI agents, revolutionizing ophthalmic education.
How's the volume here? Good?
Yeah. You're audible.
Thank you so much for the invite. It's a pleasure. And I think the last two talks, wait, who advanced the slide? Go back. The last two talks were a great intro to my talk today about using AI agents to revolutionize ophthalmic education. So I'm a full-time clinician and a super AI enthusiast. So I like to utilize the new AI technologies, and I'm going to show you some demonstrations today. basically, we talk a lot about computer vision, using some screening and prediction models, and this was trained on what we'd consider small data sets, a few 100,000 images to make a conclusion. And today we are in the world of multimodal large language foundational model data sets, and these are trained on trillions of information. It's a very different thing, which is why it can produce something now. It's the era of AI agents. So I want to talk about that a bit. Oh, no volume?
Can we have the volume?
Yeah, so maybe some of you saw the Studio Ghibli moment, right? Everyone was using ChatGPT to take their image and then put this, impression of the Studio Ghibli animation artist. And so,
welcome to the brave new world of generative AI. I can't wait to see what you think.
So that's even going beyond the image and then taking it into an animation and making video and animating the video with text that you create. So I don't have any disclosures related to AI specifically. So we heard a lot about generative AI and large language models today already from the last two talks. And I think it's better just to see what it does.
Hi, Dr. Chang. I see you're giving a talk at APAO India on AI agents. I'm not an agent, but I am a sophisticated avatar who can communicate with you like any other human. मैं किसी भी समय भाषा बदल सकता हूँ. I can help educate your patients about their eye conditions. Wouldn't this be great for patients while they are waiting to see you?
So there's a lot of things that you can play around with AI when it comes to the language, comes to the information, comes to the way that we communicate with patients when doctors have very limited time to explain the medical conditions to many patients. But I think what's really fascinating is what's going on with LLMs now becoming AI agents where they can actually execute on tasks. So what is an AI agent? Let's see one of the examples. So you heard it mentioned earlier, Manus AI. So I just show you an example here where I query Manus AI as a task to find all the trusted websites for glaucoma information on the internet. So when you ask this to do this, this is what's happening. And this is actually, I tried to slow it down because it was happening too fast to see what's going on. But essentially, the AI agent itself is breaking down the query, what I wanted to find these websites, into individual tasks. So it has to understand the language. Then it has to create actions that it can do, like go out on the web and then take a look at the individual sites and look at them. Then it has to take that information, what does the best or trusted website really mean? What are you trying to imply here? So it'll take all the information, cross-reference it from multiple sources, summarize it to output, and you get output something like this, the most trusted websites for glaucoma information. Something that we can understand by interacting with the computer. So this is actually self-coding. So we think of AI agents as a bit autonomous. They can do things like, it broke down this plan of a task. I'm going to first search for trusted information. I'm going to compile this list of websites. I'm going to verify the credibility by using a mixture of agents to check multiple websites against each other. I mean, think of it like, I'm going to go find a good restaurant. Well, let me check Michelin Guide. Let me check, Yelp. Let me check Zagat. Let me check Tomato. And then I'll cross-reference and look at the credibility to then produce the output that, maybe you have a little bit less hallucination. So this is really the era of agentic AI, combining inference LLMs, which are foundational models that do semi-thinking, with actual actions, executable things that, just like a macro that you code a computer to do, it can decide to do some of these things. So Manus is one of the first, most famous AI agents that is a general task agent that you can customize it to do things that you want. So if I think about this, how can patient education be reimagined? Well, maybe sprinkle some magic into it, right? So let's say we look at Google Gemini, we have the Google Studio here, and you want to ask, what is the best MIGS? So this is a real prompt. I put the prompt in, which FDA-cleared minimally invasive glaucoma device has the best clinical studies proving its efficacy? And you see it produce this conclusion here. So how did Google Gemini handle this prompt? It uses this prompting technique called chain of thought, which is an ability for a task to be broken down into subtasks. And this is the final Google output. It said the Horizon RCT was the best, and I would agree. But how did it actually come to that? So if you look at the reasoning model under the hood, all that information there on the side is actually what it was doing. So it's kind of a form of explainability. You can see that it first narrowed it to FDA only, then it narrowed it to what was MIGS, then it found different studies for the different tools, then it had to synthesize an answer. Look, it says acknowledge that best is subjective and depends on criteria, quantity and quality versus duration. So I mean, when we prompt, we have to be very clear and specific to the model what we want to get out of it, because that's the whole thing about AI. It can only do as good as what we're looking for it. But it's able to refine language, use nuance. It's been trained on millions of words, including all the medical terminology that it's seen throughout its training phase. So it's really getting very impressive, and I encourage everyone to try this out. Because actually, in my clinic, I have patients who are already putting all their medical information into ChatGPT to look at the possible options, understand what the doctor's saying, and then can have a conversation with me. So that's pretty incredible. Obviously, these are highly techie people in Silicon Valley. So for example, let's say for this talk, I want an original and 6-year follow-up and repeat laser studies with IOP and visual field outcomes with one slide for each study using bullet point format. Click deep research. So if you use the deep research methodology on ChatGPT, this is actually, I just took what it produced. I cut and pasted the outputs. So it was able to summarize the light trial 3-year results. Now granted, there could be some errors in here. It's not always perfect when you use LLMs, but it's getting better and better. So whenever using inference AI, you really have to fact check the output, because chain of thought is not perfect, but that's why when experts use the AI, it really empowers them. But when a novice uses the AI, they have no idea how can they check what the output is. So that's really key, is that you already have to be good at what you do, and then you use this to make yourself better. And the mixture of agents is basically cross-referencing multiple sources, helping to reduce simple errors. So now we think about glaucoma education, because I'm a glaucoma specialist. I get like 5 minutes per patient, right? All the doctors here maybe get 2 minutes per patient, 1 minute, they see 100 a day. So we say, go read about this glaucoma, here's the handout, or go to the website, and then you'll understand what glaucoma is. And as we know, some patients are good with that and some are not. So let's look at this kind of education.
Glaucoma silently steals vision, ranking as the second leading cause of blindness globally. Often it remains unnoticed until significant damage occurs, making early detection crucial to prevent irreversible vision loss. Primary open-angle glaucoma, POAG, is particularly insidious, often showing no symptoms until advanced stages. This makes regular screenings vital for early intervention and management of high-risk populations. Could artificial intelligence revolutionize glaucoma detection? By enhancing the accuracy of non-specialists, multimodal AI can lead to more appropriate referrals for early diagnosis, as well as help with patient education. POAG is marked by optic nerve damage, retinal nerve fiber loss, and corresponding visual field defects. It's a progressive condition, often linked to elevated intraocular pressure, IOP. Differentiating POAG from secondary glaucoma and normal tension glaucoma is essential for accurate diagnosis and treatment planning. It may take multiple repeat tests to confirm disease stability. Elevated IOP is the most significant modifiable risk factor for POAG. Age, race, and family history also play crucial roles in increasing risk. Myopia, thin central corneal thickness, and reduced ocular perfusion pressure are additional risk factors, highlighting the need for comprehensive risk assessments, including general medical health. IOP-related damage involves mechanical changes at the lamina cribrosa, causing characteristic neuroretinal rim thinning. Identifying these changes is essential for protecting ganglion cells. Non-IOP mechanisms, such as ischemia and neurotoxicity, also contribute to optic nerve damage, highlighting the complexity of glaucoma pathophysiology. Diagnosing POAG involves assessing IOP, optic disc features, and the visual field. Goldmann applanation tonometry remains the gold standard for IOP measurement in most cases. Gonioscopy, anterior segment, and fundoscopic examination are critical for accurate diagnosis, helping differentiate POAG from other types of glaucoma and determining appropriate laser or surgical choices. Lowering IOP is the primary treatment for POAG. SLT laser therapy is a first-line treatment, offering a very safe, non-invasive option for patients. Ocular drug delivery, such as the iDose implant, is gaining traction. Surgical options, including minimally invasive angle-based procedures and bypass filtering shunts and blebs, provide alternatives when medications and laser therapy are insufficient. Regular follow-ups are essential to monitor for disease progression. The frequency depends on risk level and disease stability, ensuring timely adjustments to treatment plans and assessing patient compliance. Target IOP reductions are based on clinical trial data and individual patient factors. Specialists can alter treatment plans to lower IOP further, improve tolerability, and slow progression as much as possible. Glaucoma research into IOP-independent mechanisms is ongoing, aiming to uncover new neuroprotective and neuroregenerative options. Lifestyle and nutritional factors are also being explored to slow vision loss. Home monitoring, such as IOP and virtual reality visual fields, could optimize glaucoma patient management, offering more personalized and AI-driven data interpretation. By leveraging crowdsourced expertise, real-world data, and Gen AI, doctors can care for more patients with improved efficiency and better access to expert knowledge for everyone. In summary, a close patient-doctor partnership is key to combating glaucoma. Every aspect from screening, diagnosis, patient education, drug discovery, practice efficiency, and home monitoring with AI summarization can be infused with AI agents in the background. Join us as we envision the future with Gen AI and AI agents embedded into the glaucoma patient experience. Every doctor needs to stay up to date with the latest AI breakthroughs, as it is now easier than ever to make a patient-friendly presentation like this without a production studio.
So I know that was a really long video, but basically I wanted to show that I could edit that video with a few clicks, change any words, change anything, and be perfectly customized for the next patient, that whatever they wanted to know. So hopefully you realize that this educational presentation, AI did everything. It arranged the written content summarized from a web link. It created the avatar herself. It created the avatar's voice. It synced the voice to the audio. It created the layout, produced suggested images. I just did editing. And you know, when that's all you have to do, you used to have to spend hours and pay thousands of dollars to produce something of this educational quality. And so that's what's really changing. So where might we be with the AI avatar patient education in the future? I think we can move away from handouts and videos. We'll be using interactive chatbots via the avatars that patients can speak to while they're waiting to see you in the waiting area. It may replace traditional web searching by AI agents finding the information that the patients really are wanting to know, not what we want to tell them. And finally, what about spreading medical education through other mediums? You know, these days it's difficult for new innovations to reach the final audience. And you know, how many people use like TikTok or other social media, Instagram? What if you could talk about things like SLT and encourage patients to not fear the laser?
I've been feeling the pressure, the number's too high. Doc says it's time for a brand new try. No drops, no pills, just a gentle light. Let's dance with the laser, keep my vision bright. It's quick, it's easy, won't take long. Eyes wide open, I'm feeling strong. A little zap here, a little spark there. SLT's the move we care to spare. Try SLT, feel the flow. Pressure's dropping, let it go. Bright and clear, a future to see. Glaucoma's chilling with SLT.
Give this to Alcon with their new DSLT laser. Anyway, the whole point is that that was also created by AI. I'm no musician. I don't do this kind of stuff on my free time. I just play around with AI to maximize, you know, creating the lyrics, creating the beat, creating the audio. Everything is all created by AI. So finally, you know, doctors' time is just really short with their patients. I want to use Gen AI and all these LLMs so that they really get more time and more understanding with what we want to do faster and better. Thank you.
Thank you, Dr. Chang, for such a lively presentation and breaking the ice for every one of us. I think I'll just ask you one question, is that these AI that you do, is it paid one, or is it freely available? How can everyone access it and make the maximum benefit of it?
Yeah, I mean, there's so much commercial software out there. It's just that if you're not in the content creation mindset, I guess you wouldn't know about it. And also, it keeps changing. So in every 3 months, there's like a better, newer version of a better model that's more realistic, that has more variety. So I do pay for all these. I pay for a lot of them now. Too many subscriptions to all this AI, but it's actually a lot of fun. So there are usually a free version that just gives you like 1 minute. But the thing is that AI is not a one and done situation necessarily. It's a more iterative process, because what creativity you have locked in your mind, you got to get it out into the computer. And when you first write it down or speak to it or whatever, there's missing aspects, and the computer just fills it in, and it may not be what you're looking for. There could be, it doesn't know gravity or something, right? The images can be totally wrong, so you have to try to use different ways. But the prompting is getting easier and easier. So I can tell you that when I first started doing this, it was a lot harder, and now the barrier is getting lower and lower all the time. So you can just try ChatGPT even to start with. It can do audio, video, text, everything. So it's very impressive.
Thanks a lot.
Any other questions, please?
Since we have spoken about reasoning models, have you tried giving image, for example, image, and seeing whether reasoning model, the current models, do they respond, do they give right reason?
Yeah, I would say for images, you know how when you generate images, it used to like have a lot of word errors and stuff. The latest model fixed a bunch of those problems, but it's still wrong. If you ask it to create a picture of an eye, it'll label wrong parts of the eye, and the eye won't be accurate. So there hasn't been enough medical illustration put into these foundational models yet for us as doctors to rely on that. But again, what these models create are basically, versions of copyrighted real stuff, right? I mean, it's kind of that gray zone that's out there, because it's absorbing all the content of humanity ever created that it can get access to, and asking for forgiveness later, and then producing something that is then slightly different than what it's seen. So with that kind of opportunity, it's only a matter of time, which they say maybe by 2027, the super AI intelligence will actually be better than the average person, any average person, expert person in one area. So it'll have expert level knowledge by the end of this year, PhD level knowledge in every single area, and I believe this is true. And next, in the 2027, it'll probably be doing things that even the expert person will be having to figure out why it did that. Kind of like in gaming world, where the games, the machines started beating the humans all the time. Yeah. I think if you created a medical-based LLM, you could do it. I think the foundational LLMs have like patient-level conversational medical knowledge, because that's what's been scraped from the entire web. Sure, retrieval augmented generation could help you fill in some of the gaps for very specific disease entities, or for, I don't know, like post-op instructions or something. And that would be a very good use case, and improve the efficiency and allow you to customize, because obviously everyone doesn't practice medicine exactly the same. And this is why the output, you have to grade them and rank them against each other. Like which LLM output is more correct or better. That's subjective, because in medicine we have subjectivity. It's not finite like a win-lose in a game, except maybe death. That's the only outcome that probably is white and black. So since like glaucoma has a lot of subjective issues about if things are controlled or if that's the right choice, the AI can't do better than what our consensus societies can do, because we have too much variability. So if you want explainability, it's definitely possible through these inference reasoning models, because they're doing things chain of thought, step by step. They're breaking it down, and you just have to look under the hood. If you look at DeepSeek, it kind of over-explains everything. It says every single possible thing, but this is definitely the direction that it's heading, and computer vision is not needed when this is the direction we're going.
Thank you.
Thank you. Any other questions? I think we are at the end of the session. I would like to thank all the speakers and all of you to make this session very lively. Really enjoyed the session. Thank you. We just come for a photograph. We'll have a photo.
All the speakers.